Okay, great. Welcome, everybody. So I would first like to introduce myself. My name is Jess Posner, and I am the Director of Virtual Programs and Membership Services at the YMCA of Central New York. Thank you so much for joining us tonight. It is my pleasure to welcome you to the third event in our month-long educational series with Syracuse orthopedic specialists, which we also refer to as SOS. Tonight's speaker is Dr. Naven Duggal, the SOS foot and ankle specialist, who will discuss the difference between bunions and big toe arthritis. So without further ado, it's my pleasure to introduce Dr. Duggal, who I'm going to invite to unmute and ask you to turn your camera on. All right.
Hi there.
Welcome, Dr. Duggal.
How are you?
I'm well, thank you. I'd like to do your full intro bio if you'd like.
Sure. Yeah, I can give you the kind of like the quick rundown.
Sure.
So I've been at SOS now almost 9 years. Like you said, I'm one of the orthopedic foot and ankle people. We are a team. There's myself, another foot and ankle surgeon, and we have 2 podiatrists who work with us as well. And we have an orthotic specialist as well. And we really do function, like I said, as a team. So we're all kind of experts within certain areas. And so we like to kind of pride ourselves on the ability to look after all foot and ankle complaints. So that's SOS. I was in practice in Boston for around 10 years before I came to to Syracuse. We came to be closer to family. And I was lucky enough that there was an opportunity that kind of arose up in Syracuse. I was able to join SOS. My specialty is foot and ankle. I do some general things as well, like when I'm on call. So I'll occasionally see some of the folks who may be on this call, if they're unfortunate enough to be in the hospital, if they break something. I may see them in the hospital for that as well. But electively, my practice is pretty much exclusively ankle and foot issues. So that's me.
All right. Well, thank you so much. If you'd like to take it from here and
Sure.
give us your show, I will turn it over completely to you. Thank you.
Yeah. So, what I was telling Nicole, who helped organize this, was that I've done discussions like this before, and in the past, I've used some PowerPoint presentations, and they've been entertaining, but they can sometimes be a little boring. And I thought that I would avoid using a PowerPoint to discuss the whole issue about bunions versus arthritis in the foot and make it a little bit more interactive. And the way I thought I would do that was to have a little bone model so that I could try to explain the difference between the 2 conditions. So number one, let's start off with bunions. It's a very, very common complaint that I see in the office. It's related oftentimes to shoe wear. So, we will see it more commonly in women than men, sometimes because of what they've worn in the past. It can be genetic as well. So there's oftentimes a story that goes along with it, that it runs within families, that somebody's mom or grandma had it in the past and they're starting to develop the same thing. And over time, some of these bunions, certain types can be progressive, meaning that they can get worse with time. Really, as a rule about treatment for bunions, it really boils down to what the patient comes in and complains about. If it's more about the appearance about the bunion, it really does not typically fall into the category of bunions that that will fix surgically. But bunions that are painful, they're sore, they're interfering with the ability of somebody to get into a regular shoe or to perform like their normal day-to-day activities. Those are bunions that fall into the category of something that, sometimes needs surgical intervention. Arthritis is similar to a bunion in that patients will come in and say, "Doc, I got pain in my big toe," but it's not typically associated with a deformity. And it's usually a history of some degree of trauma or injury that's precipitated it. Arthritis in the big toe is really common. And if you look at all types of arthritis in the foot and ankle, the most common place to have it is actually in your big toe joint. And that can be related, like I said, to prior trauma, prior injuries, but it also can be just age-related wear and tear. So I got my trusty little skeleton here. So I thought this would kind of make it a little bit more interactive. And unfortunately, there's like some little springs in between here, so it doesn't really always do this justice, but I hope everyone can see this quite well. This is a bone model of a foot, and this is your big toe. And when folks get arthritis in the big toe, hope they can see that, it is right into this joint. And what is arthritis? It's the loss of cartilage in the joint space. It's where the bone rubs directly on the bone. And oftentimes it's associated with the formation of bone spurs on the top part of the joint. The primary complaint for folks who have arthritis is it hurts when it's, when I'm walking on it. The other complaint is that motion will precipitate pain. Pain at rest is not arthritic pain. Pain with motion is arthritic pain. Things that can be done to treat arthritis of the big toe, simple things are wearing a very, very stiff shoe. If you look at any joint that's arthritic, it likes stability. And the way that people provide stability in the foot is if you can wear a shoe in which the sole is really firm so that the joint doesn't bend, or if you wear an insert. Our orthotists are really good at making inserts for folks to limit motion in the front part of their joint, and that can help you alleviate pain. And then there's other ways that you can deal with this non-surgically, such as taking an anti-inflammatory, cortisone injection. Those are all reasonable things to think about before you would ever think of surgery. If it does come to surgery for arthritis of the big toe, there's really two methods of treatment. Actually, I should say three. Number one is if the primary complaint is, doc, I got lots of spurs on the top here and they're sore and they're causing rubbing and irritation on a shoe, then the simple option is to just go in and clean out the spurs. That still leaves you with a joint that bends and it gets rid of the discomfort on the top. The problem sometimes with that surgery is that if you have underlying arthritis of the joint, just taking off the spur alone and leaving the arthritis can still cause pain. And patients may come back and say, doc, I still have pain in the joint. If that is the case, and that the spurs are removed and the pain is really coming from the joint, you're really left with two options. One is to do a fusion of the joint, which is where we put screws and plates across the joint, usually in a diagonal pattern, and it limits motion. So you get rid of all your motion of your big toe, but at the same time, you get rid of all your pain. So it's a trade-off. You're going to get pain relief, but you do sacrifice motion. Does that sacrifice in motion change the way you walk? Yeah, it does change the way you walk. It's going to cause some limitation. But from a functional standpoint, patients are able to walk. They can even run on it. They can pound on it. They can do a lot of things on it. So it does help them for pain. From a cosmetic standpoint, it's important to understand that if you get a fusion done of this joint, if you're going to wear shoes with heels, with a high inch, like a 2 or 3 inch heel, that's going to limit your ability to do that, because if this joint does not bend, it's going to be difficult to do that type of activity. If you like to do yoga, if you like to do any type of extreme activities like rock climbing, where there's a lot of bending through this joint, you may miss that with a fusion because you're not going to be able to do that type of motion. The other surgical intervention that is described for this joint is a joint replacement. And we actually do joint replacements of this big toe. If you say to me, is it the same as a knee or a hip? The answer is no, it's different. And the reason being is that we don't usually replace both sides of the joint. We usually put in a little bit of a spacer. It's like a little gel spacer that goes in the joint. It acts like a cushion. The problem with some of these joint replacements, unlike a fusion, is that right now they're kind of the new kid on the block. It's a new technology. And some of the signs suggest that that little cushion or shock absorber over time may not last forever, and it may need to either be replaced or you may need to go back and do a fusion of that joint. So the bottom line is, doing a joint replacement for this big toe, it's an option, but it's an option that you may need to pick and choose the right patient for. And the patient has to understand that the science maybe has not caught up to where we want it to be, and there may be more surgery down the road if you're doing it in a very young person. For bunions, it's a very different story. We don't like to fuse the joint for bunions at this level. We like to correct a deformity. And if you look at the front part of a foot, the reason why people get bunions is primarily due to the angle between the first bone and the second bone. And unfortunately, with this model, you can't really see it very well, but with a bunion, what happens is that the angle between the first and second bone widens. And unlike being parallel like the rest of these bones, if you have a widened angle, this big toe starts to move off to the side, and that results in what people see as a bunion. But the deformity is not really happening here. It's actually happening at the level of these two bones. So to fix that type of deformity, there's lots and lots of ways to fix bunions, not just one way. And people have done lots of different procedures where you can just shave off the bump. You can move the head of this bone over a little bit to try to correct a mild bunion. And if you have a really, really severe bunion, then the way to treat it is to do a fusion, not at this level, but at this level over here. And by correcting the joint at this level, you're able to straighten out this bone. The fusion involves, again, plates and screws to hold this joint in the right position. And it can really make a dramatic difference in the way that the foot looks and help correct the bunion. The problem with a fusion is that, yeah, even though the surgery is pretty routine, it's day surgery, you don't need to go in the hospital, there is some downtime after the surgery. There's a period of time where you can't walk on it, and that's tough. And so there's no way of really getting around that. There are tricks that we have for our patients to use, things like a knee scooter or some of these other devices that can help you travel and get around without putting weight on the foot. But there's no sugarcoating it in that for the first 6 weeks or so, you really shouldn't be putting any weight on that foot. So like I said, there's lots of options for arthritis of both the big toe. There's lots of options to treat a bunion. The right option really depends on the patient, how bad their pain is, what have they done so far for treatment, and really, are they wanting to proceed down that surgical road, understanding kind of some of the options I've discussed here. I know this is kind of a brief overview, but I'd like to kind of open it up and see if folks have questions, just general questions about bunions, arthritis in the foot. I'd be happy to chat and answer them to the best of my abilities.
Great, wonderful. Thank you so much for that overview, Dr. Duggal. I'll get us started off, but I would love to invite anybody to submit their questions into the chat, specifically having to do with arthritis of the big toe, bunions, but also it sounds like potentially other questions that you may have that Dr. Duggal may be able to speak to based on his wide range of knowledge and specialties. So let's see, we have a question already from one of our guests to ask if hammer toes fit in there.
Right. So that's a great question because it really directly relates to a bunion deformity. So I'm going to come back to my model here. So when patients get a bunion, oftentimes this big toe will deviate off to the side. The problem when that happens is your second toe and your third have nowhere to go. When that big toe moves, number 2 and number 3 have to move out of the way. And the way that they tend to go is that they tend to pop up and they tend to cause folks to develop a hammer toe. So what I'm trying to tell you is that a hammer toe is oftentimes the result of a bunion. So to fix a hammer toe, the way we fix them is that we usually remove a little bit of bone from the joint. We usually put a pin in to straighten it. But it's really important to understand that if the underlying reason why you have the hammer toe to begin with is because of the bunion, you need to fix the bunion in addition to the hammer toe, because if you just fix the hammer toe alone and leave the bunion, it'll cause the same problem and your hammer toe comes back. So oftentimes a lot of this is interrelated, and the hammer toe is a perfect example of when people get that, fixing it in isolation without addressing all of the other issues can really not get you any further ahead. So to answer your question, yes, hammer toes are related to bunions. They oftentimes go hand in hand, and they're treated the same way. If they're really symptomatic, you can't get into a shoe, if you've tried wearing a wider shoe with a widened toe box, all the non-operative things that we always want people to try first, if those things have not helped, then surgery is an option.
Thank you so much.
Sure.
We have another question from Elisa, which is, what is the downtime for inserting a gel spacer in big toe for arthritis? And to that, I'd also like to expand the question a little bit to ask a little bit more about, like how do you get to the point where you decide that that's the right procedure for you? So for example, like diagnostically, is there physical therapy? Like what does an average patient usually look like
Sure.
when they lead up to surgery and then also after surgery?
Right. Okay. So these are all good questions. So the gel spacer is very different in the downtime from the standpoint of a fusion. And that has been the advantage or the theoretical advantage of putting in that gel spacer, in that patients have said, I'm able to get back doing what I want to do quicker than the fusion, which has a long period of downtime, 6 weeks in a cast at least, followed by 6 weeks in a boot. Usually with the gel spacer, we're looking at around a month of downtime, and then you kind of get going. Like I said, the issue with the gel spacer is that we don't know the long-term life of these implants. And in some people, they haven't done very well after a very short period of time, meaning after a year or two, they don't seem to be working at all. And patients have to come back and get that fusion done. So if we're thinking of doing a gel spacer in somebody, the criteria has to be really tight. You got to really make sure that that you're dealing with the right patient, and they clearly have to understand that because the technology is new, that it can lead to some wear and tear of that gel, and potentially after a year or two, they may need to come back to get the fusion. From a rehab perspective, it's interesting in that with bunion surgery and arthritis surgery of the foot, it's not the same as, let's say, if you had like your shoulder done. If you had your shoulder done or your knee done, let's say like a rotator cuff surgery or an ACL surgery, the rehab is quite intensive. And it's actually a really crucial part of the surgery to get a good result. It's almost just as important as actually doing the surgery. The arthritis stuff in the foot and the bunion surgery is actually very different in that rehab is not a major component of the recovery. The times that I will get folks involved in rehab is if they've been casted for a long time, 6 to 8 weeks, and they feel that they're stiff, their Achilles tendon is stiff, and their legs just feel like a little weak. We'll get them off to the therapist for a few visits to give them some tips on strengthening. But it's not the same as doing shoulder recovery surgery, where it's a long rehab course where there's a lot of one-on-one work with the therapist to get range of motion back. Because with a fusion, you're not trying to do range of motion. You're trying to fuse the joint. So therapy doesn't really come into play very much for the surgery that I do with respect to bunions and for arthritis.
Okay, thank you so much for that comprehensive answer.
Sure.
We have a question about striker implants.
So I guess I'd ask for some clarification. I'm not sure what the question is specifically with respect to the implants. There are different types of companies that provide implants for bunion surgery and arthritis surgery. They all, to some degree, kind of do the same thing in the sense that a lot of the companies that provide these implants are, providing us implants that are usually either titanium or stainless steel. Those are the two types of metal that we typically use when we do this type of surgery. The reason being is that our bodies don't reject them. There's certain metals such as zinc where it can cause a significant allergic reaction in a proportion of the population, but the titanium as well as the stainless steel implants have been shown not to have that type of reactivity. Oftentimes when we fix a bunion or we do arthritis surgery, we're using a series of plates and screws. And it's pretty universal. So it's not just the striker implants, but it's really all the companies that have these sets of plates and screws that we use.
Thank you. I hope that answers your question about the striker implants. To Linda. All right. So we have a question from Cindy asking if a dorsal bunion is caused by arthritis.
Right. So this relates on to that idea of folks who have a dorsal bunion. And a dorsal bunion, the terminology that I use for it is hallux rigidus. And what does that mean? It means that there's essentially a bone spur on the top part of this joint. And that's exactly what a dorsal bunion is. And you are correct in that, is it related to the arthritis? Oftentimes it is. One of the hallmarks of arthritis is spur formation. And so when folks get a dorsal bunion, it's really their body's producing a spur secondary to the arthritis in the joint. And so, when I see a patient, there's certain tricks and certain, ways that I try to differentiate about which patient would benefit from what type of surgery. If patients come in and say, "Doc, my biggest complaint is the bump on the top part of the joint. It rubs on my shoe, but I'm able to move the joint with no pain. I'm able to run, I'm able to do all my activities," then likely it's not the arthritis that's talking to them. It's likely that bump that's causing them most of the pain. And for that person, if we're going to talk about surgery, shaving the bump alone usually does the trick. If I have a patient who comes in and says, "No, my pain is deep. It's deep inside the joint. It hurts when I do any type of push off. It hurts when I try to load the joint." And the way that I like to examine patients is when I'm in the office, I'll actually physically push in the joint and see if I can irritate it a little bit. And if that really irritates, especially going downwards, that usually tells me that the arthritis is kind of deeper within the joint. Then for that patient, especially if their arthritis on the x-rays is really bad, then sometimes just doing the chylectomy or the bump removal type surgery is not really adequate. And for that patient, usually a fusion is a better surgery.
Thank you. We have a question about the efficacy of the different like braces or glove types of things that are advertised to help with bunions. And our guest asks if those help your toes get trained, or if they can move over time, or if they really just provide temporary relief when you wear them.
Another really good question, another really common question. I have a lot of patients who come into the office and ask me the exact same thing. And unfortunately, all of those sleeves and devices that are out there, they really do not correct the underlying deformity. They will not help treat the deformity. They don't help train any of the muscles to kind of do their job. That being said, I do have folks who say, "Doc, I use this, it helps me, I get pain relief from it." And from my perspective, I'm not going to argue with that, because if they're able to use that device and do all those activities that they want to do and feel that it actually helps, and they don't need to take medications for it, and they can avoid surgery, that's a win. And I think that's a good thing. But if you say to me, do I go out of my way to tell all my folks to actively buy these things? I have to say, I actually don't. I'm okay with folks using them, especially if they say it helps me, but I really can't tell them in all honesty that using one of these devices is going to change the history or the progression of a bunion or arthritis, because the science doesn't back that up. It's really more for symptom relief more than anything else. If it helps you for pain relief, great, continue to use it. But I would not use it with the hope or the anticipation that it's going to change the progression of your bunion, because it won't.
Thank you. I'm going to encourage people to continue to ask questions, or if there's anything that you have a follow-up about, please go ahead and put that in the chat. Let's see. All right, we've got another one. Is there any way to tape the big toe or foot to limit movement and pain? So like more questions about those sort of like non-surgical, superficial tools.
Right. So really common to have complaints related to motion of the big toe. And it's important to just kind of preface this by saying arthritis is one cause of pain within the joint. There's a lot of causes of discomfort in the big toe. It's actually a pretty complex little joint. It's the main power driver in your foot when you do push off. And there's some other little bones that sit underneath of your big toe joint. It doesn't really show, well, you can kind of see them over here, hopefully. There's these two little bones over here, and they're called sesamoid bones, and they sit on the bottom side of your big toe joint. And those little bones are part of a kind of a complex system where there's tendons that run through the bones themselves, and there's a very thick cartilaginous plate. And I'm not sure if folks have heard of an injury called turf toe. Patrick Mahomes, who's he's a quarterback for the Chiefs. He had a turf toe injury that needed, a surgery because of the fact that he tore that thick cartilaginous plate on the big toe. But his toe was really aggressively taped up when he was in the Super Bowl. And that's how he was able to continue to play. Unfortunately, he didn't play that well. That's why they lost. But anyways, that's another story. But to answer your question, yes, you can tape the big toe. I have to say, I'm not the expert when it comes on to describing the best way to do that. I'm lucky. I'm really fortunate that at SOS, we actually have a really, really good PT department, physical therapy department. And what I'll do for a lot of my folks who have symptomatic turf toe, but do not have a full tear of that cartilage or the tendons, I'll usually have them seen by our physical therapist, and they will talk to them about the most effective way to treat and stabilize and potentially tape that big toe as well to give them stability.
Thank you so much. We have another question, this time from Jim, who says, thanks so much for this presentation. About 2 years ago, he went to stiff sole shoes and it's really addressed the foot pain, but it affects his hiking and running gait and he thinks has led to back pain. Is that common or even likely?
So it's interesting. When I was in Boston, I did a study, and it was a biomechanical study, and it looked at people who had issues in their ankle. And we tried to see how does that change the other joints, because a lot of folks will say, you know what, I have an issue in my ankle and I'm convinced that I have hip and knee pain as a direct result because it's throwing off my alignment, it's causing other issues. And I heard that so many times in the office that I said, I want to look into this from a mechanical perspective. And what we did is that we actually had these cadavers and we designed a testing jig in which we created deformities in the ankle to either give people a really flat foot or a really high arched foot or a really stiff foot. And then we put pressure sensors into the knee joint and into the hip joint of these cadavers. And then we loaded them to simulate putting normal weight on that leg and normal walking. And there was a change in the pressures of the knee joint as well as the hip that directly correlated to what we did within the ankle and the foot. So to answer Jim's question, I think there is some connection between changing your shoe wear or wearing an orthotic or any of these devices that can precipitate changes in joints above and below that joint, such as your knee and your hip. The thing that we don't know, which still is the big unanswered question, is how much of an issue is this and does it cause damage? And right now, I don't have an answer to that. We know that there's some mechanical changes that we see in the cadavers when we test them, but we don't know what happens in real life. To answer your question, I think wearing the stiff shoe, it's going to likely, like I said, help you for some of the arthritis pain, but it can cause some changes in your gait that could precipitate knee and hip complaints, lower back complaints, and I hear it all the time.
Do you have any recommendations for folks that are sort of experiencing this new discomfort, I guess, that comes out of fixing one pain?
Yeah, it's a little bit of chasing the problem. And so sometimes it's a matter of taking a step back and making sure they're wearing whatever they're wearing shoe-wise or orthotic-wise is not the root of the problem. So that's number one. If it is, trying to alter or modify what they have to still provide them the relief at the level of their ankle and foot, but alleviate some of the altered mechanics in their knee and hip is another way that you can try to do that. And our orthotist, Maureen, she's fantastic for that type of stuff. So she's able to give us a really solid opinion on what we can do to the orthotics to modify them to make them hopefully less painful. But I have to be honest with you. I have a lot of folks who are exactly like Jim in that we help them in one area, but that help may precipitate other issues. And there's unfortunately not a quick fix, because if we say just take out the insert, go back to your old shoes, then they're left essentially with the complaints of foot pain. So.
All right. Thank you so much. It's a pleasure of having a body, right? Where everything's connected.
Right.
We've got another question about if everything that you are describing, so arthritis, bone spurs, turf toe, can be seen on x-ray.
So good question. Arthritis, for the most part, if it's to the point where we get joint space narrowing. So remember, I mentioned that one of the hallmarks of arthritis is getting a bone spur. That's one of the hallmarks. The other hallmark of arthritis anywhere in our body is joint space narrowing. And joint space narrowing is if a joint has a normal joint space, meaning there's a normal space in the joint here. With arthritis, the joint narrows and closes down. And we can see that on an x-ray. So yes, to answer your question, we can see arthritis on an x-ray if it's at that point, if it's progressed to that point where the joint has started to narrow and it's resulted in spur formation. Those are very visible things. If arthritis is really early, really early, and it's not so much that it's caused joint space narrowing, but it's caused some wearing away of the cartilage, which is this smooth cushion that sits on the top of the joint, then that's stuff that you won't see on an x-ray. That'll likely only be visualized on something that can visualize the cartilage, and the test of choice for that is an MRI. And an MRI will show that. Turf toe, which I think is the second half of that question, is, again, it's kind of one of these twofold answers. If you have turf toe, and we're talking really bad turf toe, and you've completely ripped that cartilage, these little sesamoid bones normally sit at a certain level, and we'll see that on the x-ray, but for the really bad ones, the sesamoids will then move, and they move where they're not supposed to be. They end up sitting at a level where we know for sure that the person's torn their cartilage on the bottom part of that joint, and the sesamoids have migrated, they're moved. And so we'll see bad turf toe on an x-ray. If it's mild turf toe, since it's cartilage we're looking at, the only way you can visualize cartilage if it's a mild cartilage injury, again, is to go to an MRI, because that's the test of choice to look at cartilage as well.
All right, thank you so much. I have a few questions actually that I'd like to ask, but I'd also love to encourage people to keep them coming on in. So how did you get into this? You are so passionate about it, and have clearly spent so much time helping people, and the research is so fascinating. So I was wondering if you could talk a little bit about how you got into it.
Yeah, so I actually, after my orthopedic training, I actually wanted to be a knee person. So orthopedics is kind of one of these subspecialized type of specialties where the days of the general orthopedist who's an expert of every single body part, they don't exist anymore. We all become experts within certain areas. And at the end of my residency, a long time ago, I had said, okay, I want to be a knee expert. And I had gone to Australia to do a fellowship. And for a full year, I just did knee replacements, ACL surgery, everything related to the knee. And at the end of that 1 year, I said, I just don't find this as exciting as I really thought it would be. And so at that point, I started thinking, what else can I do that gives me variety? And that was the kind of stuff that I missed. And I like trauma. I like injuries. I like treating injuries. I like sports stuff. I like doing complex fusions. And foot and ankle is one of these specialties that lets you do all of that stuff. So that was the real hook for me to go into foot and ankle, was that I could get all those things that I missed when I just did, joint replacements or knee sports surgery. With foot and ankle, you can really be an expert, but cover bases such as sports and fractures and fusion. So I get to kind of do it all by doing foot and ankle.
Oh, it sounds like there's an interesting opportunity to be creative too, in some ways.
It is, and it's as much as I admire what my joint replacement friends do. To be a really good knee or a hip replacement doctor, you're doing the same surgery very well every single time, and it's a lot of the more you do, the better you become. And so when you look at joint replacement doctors who are very good, those are those are the folks who do a lot of that type of surgery, and it becomes very second nature. With foot and ankle, just like you said, everything, like every single case is really unique. there's no reproducing it. It's so there's a lot of variety, and it's a little bit like being a chef in that you have to really kind of look at things and simulate when somebody puts weight on it versus when they're not weight bearing. It really changes the position of the foot, and trying to figure that stuff out can be kind of complex at times, but I like the challenge of it.
Yeah, that's so interesting. And it duplicates or echoes what Dr. Kopko actually talked about in terms of hip and knee replacement, that like
Right.
when you're looking for one of those surgeons, you want like a high volume person
That's
because they
right.
are, like
Right.
rote at it.
That's right. But it's important to understand that the foot and the ankle is much more important than the hip and knee. You can tell Kevin that as well.
Well, they'll all, all the recordings will live somewhere. So we'll let you all take that up with yourself
Right.
in the office. So one of the questions that's actually come up over the course of the series is, at what point should someone seek medical advice if they are experiencing foot pain? Because of the pandemic, and I think also a lot of people maybe have a high pain threshold or,
Right.
Whatever it may be, or they believe that it's not bad yet, right?
Right.
Or they've lived with it for a long time. So can you give advice on when folks perhaps should see a specialist or when they should come in?
Right. So, it's interesting you asked me that question. If you asked me that question 1 year ago, my answer would be very different than what I'm going to tell you right now. And I remember that a year ago when this whole pandemic started, we had to literally triage as the physicians a lot of the phone calls and referrals we got in and find out if this was something that we could do virtually or if it was bad enough to actually have folks come in. Now, thankfully, knock on wood, we're moving in the right direction, and we're starting to kind of try to get back to some degree of normalcy. That being said, a lot of the measures with respect to keeping the offices clean, social distancing, wearing a mask, that's still stuff that you're going to see if you go into pretty much any doctor's office, and for sure if you come into any SOS office, guaranteed. With respect to when to come in, I'll tell you that I think a little of that depends on the acuity of the pain. So I feel that if patients have had something traumatic and they have a known history or a specific mechanism of injury, and it's now to the point that they're having trouble weight bearing, to me, that is kind of a red flag that needs to be checked out. If patients have had something traumatic, they have very little pain, they can fully weight bear on it, they have full range of motion, those are sometimes things that may be able to wait a little bit longer until coming in. But really the kicker for me would be if patients' range of motion is significantly decreased, if they can't put weight on that extremity, and if they've had a significant mechanism of injury, such as, they twisted their ankle severely, they did something while they were playing sports, at work, that's stuff that really shouldn't be ignored, because just like you said, we don't want to miss something that potentially when patients present late after that injury's happened, the options for treatment may have changed. The chronic stuff, the stuff that patients have had for a long time, I think that's a little more subjective. I think it still comes down to how much is this interfering with the quality of your life? What have you done on your own? And really, a lot of my patients, when they see me for some of the chronic conditions, they've oftentimes tried some of the easy stuff that I've talked to them about, like changing their shoe wear, changing their activity level. A lot of patients have tried those things, and they're really seeing me in the office because those things haven't worked. And I also totally get it with respect to COVID. People have to feel comfortable coming into the office, and that's a personal thing as well. And what we've done as well is that we've also arranged Zoom calls, and I still do them as part of my practice, where we'll try to Zoom call as much as we can with patients. It works, but there's limitations to it. There's only so much that we can do with orthopedics through a Zoom call. I think there's certain things, such as if we do an MRI, I like to see my patients sometimes for a Zoom call for a follow-up, because it saves them a trip into the office. It makes it convenient. But sometimes trying to do an exam over the computer, or to try to diagnose things over a computer, can be a challenge.
Thank you so much. We've got a few more questions coming in. One, which is, what could be a painful bump on the side of the foot, but opposite side of the big toe, like on a
Right.
foot that has a bunion of the big toe and a second toe, hammer toe?
Right. So that, I think the bump that that the person's referring to would be a bump on your fifth toe, which is over here. And that's actually what we call a bunionette. And a bunionette is kind of the cute term for saying that you have a bunion of your baby toe. And it's essentially the same thing. It has to do with the angles between number 4 and number 5. When the angle between these two bones changes, patients get a bunionette of the fifth. And it's treated in a similar way to a big toe bunion over here, in that we get folks to wear wider shoes so that they don't compress on the bunion. I have a lot of folks who've done really simple things like wearing a corn pad on the bunionette to make them feel better. Hey, if that works, great. That's what I want you doing. But if things are really bad and painful and it's interfering with your ability to do normal things, and you've tried the easy things, and we'll go ahead and do something similar to what we do surgically on the bunion, in that we'll shave a little bit of this bunionette, and then we have to shift it over and use some screws to hold it in place, and that'll help correct the deformity. But like I said, easy things are always easy, and I always stress to people, if we can avoid surgery, it's a good thing.
Thank you. All right, we have another question. Does a fusion allow any movement in the joint, such as standing on your toes to reach something overhead, or are you totally flat-footed?
So I would say that it depends a little bit on which joint you're fusing. If we're talking about the big toe joint and we're fusing the big toe, then yes. If you're trying to do things that involve bending of the big toe, if you're trying to do stuff that involves motion of this big toe and you need to be able to bend it, the joint's going to be fused in this position and you will not be able to do that. That being said, once the joint is fused, you can still bend through other joints and keep this joint fused, and still usually be able to do what you're describing, which is reaching for things and getting, being able to extend upwards. I think the biggest complaint or the biggest restriction that I warn my patients about for a fusion is not so much doing day-to-day things, it's really the extremes. So if you're somebody who really likes to do yoga, and yoga involves the extremes of bending of that big toe, that's something that you may not be able to do. If you're somebody who likes to do the extremes of activities such as rock climbing, that involves really the ability to bend that big toe so you can get into crevices to climb up a rock face, then that's going to be limited. If you're somebody who wants to wear a heel that's over 1.5 inches, then you're going to be limited. So there's those type of limitations that you have to really accept before you get a fusion. But there's certain things, such as the day-to-day stuff, I find that our bodies are able to accommodate around once the joint's fused, and you're still able to do those things, without too much difficulty, as long as you're not trying to do the extremes.
Thank you.
Yeah.
I have another question, and I'd like to also invite anyone, if they have any final questions, to go ahead and submit those so that we can, begin to move towards closing the evening. So please go ahead and put those final questions or comments in the chat. But my question would be, do you have advice on preventative health foot care? Like, are there things that people, like, if they aren't necessarily experiencing foot pain now, are there things that you would suggest that they do to maintain longevity of foot health?
Right. So I'm going to answer that with 2 responses. I think if patients have a history of certain systemic issues, there's a real importance with respect to foot health. So number 1 on the list, diabetes. And if you're a diabetic, and a type 2 diabetic typically, and you should make it part of your mission every single day to look at your foot, to make sure that the bottom side of your foot, the plantar surface, if you need to, get a mirror so that you can actually look at the bottom, to check and inspect to make sure that you do not have a sore or ulcer forming. Diabetics oftentimes have loss of sensation. Loss of sensation means that when they stub their toe, if they step on something, they won't know it. And it can lead to some horrendous infections. Patients can lose their legs because of these infections. So I'm going to answer that question by saying if you have certain systemic conditions, neuropathy, diabetes, any of those things, daily foot inspections to make sure you don't have sores or blisters or any of those things, mandatory. Now, I think the other half of this question is that in general, are there things that may be able to prevent you from getting things like stress fractures and maybe some degree of arthritis and some tendon and ligament issues? I think the number one thing that patients can do to decrease the risk of that is to see if they have a tightened heel cord. So I see a lot of folks who come into the office with stress fractures, they have really flat feet. And one of the things I notice on a lot of these patients is that their Achilles tendons are exceptionally tight. They don't bend very well. So when they try to bend their ankle backwards, they kind of stop at this level. They don't go all the way back. And the fact that they're limited is because their Achilles tendon in the back here is extremely contracted and tight. And there's some good science to suggest that patients who have some of these contractures of their Achilles tendons or their gastrocnemius, which is one of the muscles that make up the Achilles, they can sometimes be more prone to developing some of these injuries that we see frequently, stress injuries of the foot. So what I encourage all my folks to do is that once your fractures are healed, proactively, I want you to be somebody who stretches every single day. And not just like a feel-good stretch. I want you to stretch. I want you to really feel sore in your Achilles and your calf. I want you to really give the Achilles a good stretch. It should be part of your daily mission. And I tell that to all my runners is that if you want to do any one thing to hopefully decrease the risk of an injury, that's the thing that should be part of your daily schedule. It shouldn't be anything that you should ignore.
Can you give us a little more specifics about what kind of stretch that might be?
So there's different ways to do this. There's ways to isolate the gastrocnemius. So when I see patients in the office, you can either have an Achilles contracture or a gastrocnemius contracture. And the way that we treat them are very different. The gastrocnemius muscle gets relaxed when you bend your knee. And so when I see those folks in the office, they're very tight despite bending their knee. So I know it's their, I know it's primarily their gastrocs that's problematic. I again will defer to the fact that I'm lucky I have a team behind me. So when I see those folks who have a gastrocnemius contracture or an Achilles contracture, I usually say, listen, I want you to go see the physical therapist for a 1-time or 2-time visit. That's it. I don't want them to go see them for a million visits, but I want you to go see them once or twice to learn so that they can teach you how to torture yourself. And I want you to be your own therapist and make it your daily mission to do what the therapist has taught you with that one visit every single day. Make it part of your 7 days of routine, 7 days a week routine. And you're just going to make it part of just like waking up in the morning and you do your stretch. So you don't even forget about it. And I like I said, I'm spoiled. I have all these people around me who are experts. So when I diagnose something, I usually just say, all right, I'm going to get you to see the expert. They're going to take care of you.
Great. Thank you so much. That's so great. And it's also one of the things that we've really learned over the course of this series is that the comprehensive care that you guys offer at SOS seems really amazing, where, the specialists can really focus on their thing. And then you have this team to really support people.
Yeah. This is very unique. Like I said, I was in Boston in 10 years, for 10 years, almost 10 years in practice at one of the Harvard teaching hospitals. And it wasn't even close to the integration that you have here. And it really makes a difference. I'm convinced about that. It actually really makes a difference when things are so connected. Because I think you get better patient care in the end by having that connection with the team.
Wonderful. Looks like we've got one final question, if you're good to do one more.
Yeah.
So this is from Tish, asking if you could please discuss the causes of numb or tingling, painful second and third toes.
So this is interesting. I see a lot of folks who have complaints related to numbness in their foot. And one of the first things I ask them is, are you diabetic? And do you have issues with your back? And the reason why I ask them that is that there are certain conditions for sure that cause numbness and tingling in the toes. And from Tish's description, it can be something called a neuroma. And a neuroma is a nerve that travels. So all the nerves in the foot travel between the toes. And once they hit this level between every single toe, so between, let's say, toes 2 and 3, like in Tisha's case, the nerve sends off a branch to either side of the toe. And a neuroma means that this central point of the nerve gets inflamed and irritated, and it can cause folks to have numbness. But for me as a clinician, I got to make sure that that patient's numbness is not coming from a different level. And typically that means up in their spine. So really we need to make sure that this is not a non-foot and ankle related complaint. Is it something coming at a higher level? Oftentimes, again, it comes into the team concept. I'll have one of my spine friends or the spine team evaluate that patient if I'm concerned that it may be at a different level. If it's a neuroma that we're trying to visualize, I tend to be pretty black and white about these neuromas. You can't see them on an x-ray because it's a nerve. You can't visualize it. And oftentimes what I will do is I'll get an MRI of that foot to confirm that they have a neuroma. The reason being is that one of the treatments for a neuroma is to sometimes put an injection in there to see if it alleviates patient's pain. Like I said, I want to know that you have a neuroma before anybody does an injection on you, because there's no use doing an injection if you don't have a neuroma. So I want to confirm it. The way that I typically do it is I get an MRI of that foot. If there's a neuroma that's significant in size, then we try to do a ultrasound guided injection to see if it alleviates your discomfort.
Thank you so much.
Yeah.
And with that, I just would love to express an incredible amount of gratitude for your generosity, for the information, for the really friendly way in which you answered these questions and gave us this really awesome opportunity to learn tonight. And that's definitely been reflected in so many of the comments, just saying thank you, excellent presentation, really expressing some love for SOS. So thank you. So thanks so much for being a part of our series. It's really been a lovely evening learning with you. And I just want to thank everyone who's logged on as well. And are there any final thoughts that you have, Dr. Duggal, that you would like to share with everyone here?
No, like, I mean, I have to say the people who were on this call gave some really, really good questions, and like stuff that I see very commonly in the office, really kind of pointed questions about foot and ankle stuff. So, and thank you for moderating. Like, I mean, this was a great call, and it went very smoothly. So I appreciate your organizing this.
Well, you're so welcome. And I'd like to thank Nicole and the other folks at SOS who have made for a really interesting series. And just remind everybody that next week we have our final event in the series with Dr. Todd Battaglia. So I'm sure he'll give us some more good information to kind of like wrap up our month-long series with SOS. So thanks again, everybody. Really grateful to have you all here, and we'll see you again soon.
Take care.
Good night.
Bye-bye.